My patient is a 71-year-old Asian female who presents for follow-up after hospital admission 1 week ago. She was admitted for one episode of postprandial GERD that was severe and precipitated hematemesis. She vomited about 1 cup of bright red blood. She was treated in the hospital with IV Protonix and octreotide. She did not need a transfusion, and since discharge, she has not had any other episodes of acid reflux or hematemesis. She has continued on the PPI, and she has reported generalized fatigue, which has been ongoing for the past few months. She has not had any other episodes of dysphagia or dynaphasia. She's not had any abdominal pain or fullness or nausea or vomiting, and she does not report any yellowing or itching of the skin. Her past medical history is significant for ileocecal abscess with GI bleed and 2 episodes of cholelithiasis with then subsequent ERCP-induced pancreatitis just last year in 2014. She has chronic iron deficient anemia, and she also carries the diagnosis of Crohn's. Most recently, she was diagnosed with acute hepatitis B in July of this year. And at the time of her diagnosis, she reports the 2 main symptoms were lower extremity edema, both legs, and an orangish tint to her urine, both of which have resolved since then. And of note, patient does report recent travel to the Philippines several weeks prior to her diagnosis. So on exam, vital signs stable, afebrile, no apparent distress. Her skin was intact with no evidence of telangiectasia or purpura, and there was no jaundice or scleral icterus appreciated. Her abdomen was soft, non-tender, non-distended. There was no shifting dullness or palpable fluid wave. There was no engorged epigastric vessels. Her heart exam was normal, and there was no lower extremity edema. Her CBC showed a stable H&H. Her PT and iron R were elevated at 22 and 2, and her LFTs were elevated. AST was 149, ALT was 94. This has come down since her diagnosis in July, but is still elevated. And her most recent acute hepatitis panel showed a reactive surface antigen with a reactive surface antibody, but there was a non-reactive envelope antigen and a non-reactive envelope antibody. And there's also a non-reactive core antibody, which is unusual. We would expect her in the acute phase of hepatitis to have a core antibody that was showing as IgM. Her HBV DNA has come down since her diagnosis in July, but it's still high at 6.5 log copies. And finally, her diagnostic ERCP, which was done in hospital, showed portal hypertensive gastropathy and small varices in the distal third of the esophagus. And this is a new finding since the ERCP she had performed in 2014. So this has developed over the past year. Assessment and plan: esophageal varices, portal hypertensive gastropathy, and elevated LFTs. So differentials for varices could be a Mallory-Weiss tear, GERD with esophagitis, or Crohn's disease of the esophagus. The portal hypertensive gastropathy could also be gastroenteritis or an upper GI bleed or a gastric ulcer. And the elevated LFTs most likely due to acute versus acute on chronic HBV. At this time, it's kind of unclear given her unique serologic profile. Differentials include any type of viral hepatitis or alcoholic hepatitis, acetaminophen or any other hepatotoxin overdose, cirrhosis, and then cholecystitis and choledocholithiasis. So our plan is to continue her on the Protonix, 40 milligrams twice a day to reduce her acid reflux, help with those varices. Start her on a atenolol, 50 milligrams twice a day to suppress the portal hypertension in her stomach. And then to go ahead and start her on tenofovir. I'm going to talk about this more later, but given her clinical complications of cirrhosis already starting with the varices and the gastropathy, and then also she has obviously acute viral disease due to the high levels of DNA and the elevated liver enzymes. We're going to continue to monitor her CMP every 3 months, and we're also going to check an alpha-fetoprotein every 3 months because we know that chronic HBV has a higher increased risk of developing hepatocellular carcinoma. And then we're going to continue patient education on abstinence from alcohol and other hepatotoxins, including Tylenol, and then as well hand hygiene to reduce the risk of transmission to the people that she's living with. So hepatitis B virus is a global health problem. We talk about hepatitis C a lot more, but there's 250 million carriers in the world and 600,000 deaths each year. So it's by far the most common hepatitis in the world. Anatomy and physiology: we know it's liver disease with extrahepatic manifestations and complications. Abnormalities you look for on physical exam: obviously jaundice, the yellowing of the skin, and then scleral icterus. You can ask patients about the color of their urine and the color of their stools. You can feel for hepatosplenomegaly. Look for a distended abdomen with palpable fluid wave and shifting dullness, and those engorged epigastric vessels, also known as caput medusa. You obviously look for peripheral edema, and then asterixis is a poor prognostic prognostic factor for late disease, that ammonia buildup because the liver is not clearing it. So all of these signs would be present in a decompensated cirrhotic, which thankfully is not most patients with HBV. Usually we catch them ahead of time and they're not progressing to this place. So the pathophysiology basically comes down to the inflammation of the liver due to the virus, and then that leads to decreased synthetic function of the liver, meaning decreased production of albumin, which causes fluid overload with ascites and portal hypertension, coagulopathies because the liver's not making clotting factors, and then the hyperbilirubinemia because the liver's not conjugating the bilirubin, and that shows up as dark urine and light stools. And then, like I said, the encephalopathy because the liver's not clearing the ammonia. So clinical manifestations in acute HBV, the majority of patients are going to present in the subclinical phase, 70% of them, and only 30% will present in the icteric phase, which is what our patient presented in. So the incubation period is about 1 to 4 months, and then that's followed by this prodromal or pre-icteric or anicteric phase. And in this phase, you have a gradual onset of anorexia, malaise, fatigue. The liver is becoming inflamed and the enzymes are starting to rise. And about 15% have a serum-like sickness with fever, rash, and joint pain. After that, you progress to the icteric phase. The liver is now extremely tender. Jaundice develops, as was the case with our patient. This is when she presented. There's nausea, vomiting, and pruritus. And then after that, symptom progression is varied along a big scale. You have some patients that improve rapidly, others that take a long time, and some improve and then relapse, and then very few, thankfully, less than 1%, progress to fulminant hepatic failure, which usually happens over a few days. So the jaundice resolves within 1 to 3 months, but the fatigue persists, as was the case with our patient. Chronic HBV, many people are asymptomatic unless they have decompensated cirrhosis, and that's what we look for on exam that I already talked about. You would expect moderately elevated liver enzymes in chronic disease, but nowhere near as high as in the acute phase. And then the extrahepatic manifestations are only seen in about 10 to 20% with that serum sickness, and then the polyarteritis nodosa and glomerular disease. Complications, end-stage liver disease with cirrhosis and portal hypertension. This may necessitate a liver transplant, and then also the increased risk of HCC. Differentials are any other type of viral hepatitis. You also could think about infectious mononucleosis with the splenomegaly, drug-induced liver disease, the acetaminophen overdose, and then ischemic and autoimmune hepatitis as well. Diagnostics, this is a big headache. To make it really simple, the surface antigen is what we look at as the hallmark of infection. It usually shows up 1 to 10 weeks after exposure. If the patient recovers well, then it will disappear within 4 to 6 months. If it is present more than 6 months, then we consider the diagnosis of chronic HBV. And the surface antibody obviously shows up as the antigen disappears. And there's sometimes a window in between, and then in about 25% of patients, they coexist, which is what was going on with our patient. She had both the surface antigen and the surface antibody present. And this persists for life. And this is the one that you cannot differentiate whether a person has been infected with the disease or was just vaccinated, because the surface antibody will be there either way. The core antigen, this is the one that's expressed as IgM first and then IgG. Neither was present in our patient at the time of her diagnosis, which is extremely atypical, and the gastroenterologist that I was working at was very puzzled by that. The envelope antigen, this is expressed as a pre-core protein, and unlike the core antigen, this one is variable. Some viruses are considered a genetic variant, and they don't express this, and that was also the case with our patient. She did not have an envelope antigen or antibody. And then obviously the DNA levels are used to assess whether or not the patient is in active replication, as our patient was. Aminotransferases can be elevated up to 1 to 2,000. Again, if the ALT or AST is elevated after 6 months, then we consider the diagnosis of chronic disease. Treatment, very controversial. It's based on active liver disease and the levels of HBV DNA. According to the National Institutes of Health, treatment is absolutely indicated for acute liver failure and clinical complications of cirrhosis, which again our patient had, and then cirrhosis or advanced fibrosis with the high serum HBV DNA. And treatment may be indicated if that envelope antigen, which is a marker of acute infectivity, if that is positive, or if that is negative but the patient has progressed to chronic, then treatment may be indicated as well, because we know that those chronic HBV patients are at an increased risk for HCC. So you may want to consider treating them as well. The main treatment options are interferon and then the antivirals. And interferon is contraindicated in active disease, so you need to have 3 rounds of negative surface antigen in order to initiate treatment. And it's really primarily good for younger patients who are healthy. The side effects are pretty nasty, so you want to treat younger patients who can handle that. And the antivirals, we chose tenofovir because it's considered first line in patients who have not been treated. It's very effective against multiple drug-resistant viruses, and given that our patient may have a variant virus because she didn't have that envelope antigen, this was the most appropriate choice for her. Duration of treatment is not well known. Most require 4 to 5 years, and some may need indefinite long-term treatment. The surgical option is obviously liver transplant, and the alternative treatment it's not really an alternative, but just to encourage that abstinence from alcohol and hepatotoxins. The prognosis really depends on the host, whether or not they have chronic other concurrent liver disease, and their overall immune state. They can progress to an inactive carrier state or a chronic replicative carrier state, and that is really based on whether or not they have active HBV DNA and whether or not they have elevated liver enzymes. The rate of progression from acute to chronic, like I said, it's less than 5% for adult to progress from acute hepatitis to chronic, and that means that antiviral treatment is not always indicated for acute infection. You really have to go by their level of decompensation or compensation with their liver disease. And lastly, the treatment of hepatitis B is obviously far from straightforward, but there is clear data to show that if the patient has that envelope antigen that's positive and their ALT is more than 2 times the normal limit, and they meet the criteria for treatment, as we already talked about, then they should respond with seroconversion and a decreased DNA level from before they initiate treatment. If they do not have a positive surface antigen, as our patient did not, if they do not have a positive envelope antigen, then the prediction of whether or not they will seroconvert as a result of treatment is less clear. So you really just have to take into account the patient factors and where they're at with their disease. So that is acute hepatitis B. Thank you.